You've heard that St Mark's has been really at the forefront now of innovation, and Dr. Gabe has already mentioned a list of firsts that St Mark's has been achieving. These are mentioned again here, and I think for me, I certainly see this as the inspiration to really try and springboard us into the future and make sure that we continue to make sure that we're doing things right at the forefront of what's going on. So as you can see, the first to look into the rectum, the first description of colonic Crohn's disease, the first trials of the major drugs that we still use today in IBD, widespread use of azathioprine, the first controlled trial of a biologic drug, the first cancer surveillance program, the innovation of the pouch, an incredibly important innovation in IBD surgery. And again, we were part of the first group that found a gene involved in Crohn's disease. Again, the history of this place, I think, really inspires me to take things forward into the future. And here's some pictures again of the old St Mark's. But of course, this is where we are today, the door that you came in through the front. So this is the mission statement for the Inflammatory Bowel Disease Unit here at St Mark's. St Mark's is a centre of excellence which offers individualised, exceptional, multidisciplinary care for people with inflammatory bowel disease, allowing healing of the disease and empowering them to lead normal lives. And I think actually the last two bits of that are really important, that we now really have tried to raise the bar with what we aim to achieve with inflammatory bowel disease. It's now no longer good enough that you come back and say you're feeling better. We really want the bowel to be healing better. And that coupled with doing what you want to do, leading the life that you want to lead, and trying to empower you to do that. So at St Mark's, in the Inflammatory Bowel Disease Unit, we're really lucky to have a large team. There are in total 15 gastroenterologists, 10 surgeons and 5 main clinical nurse specialist teams, the inflammatory bowel disease team, but also the biofeedback team and several others. I've got the great privilege of leading from the physician's point of view, and Mr. Janindra Warasavatani, who you'll be hearing from next, leads from the surgical point of view. Marion, you've already met this morning, you'll hear more from her this afternoon, and we're incredibly lucky to have her as our lead IBD specialist nurse. We really do genuinely have a multidisciplinary team approach here. And this isn't just having meetings every now and then. I've mentioned 2 definite meetings a week. This is a very genuine multidisciplinary team where we interact daily with our colleagues, with your interests at heart, actually. These are some of the doctors, and you'll recognise some of the faces maybe of the consultants who look after you there. But these are the members of the team. You can see it's not just the doctors, the surgeons, the nurses I've mentioned, the stoma nurses, the pouch nurses. We've got the nutrition team, and you've heard from Dr. Gabe this morning. Really lucky to have that on site here. We've got the therapeutic endoscopist. There's really nothing that can't be done endoscopically here at St Mark's, and Shu and Thomas Gibson will tell you a lot more about that later. We've got a very dynamic clinical research team now, and we're lucky to have Lawrence Penners, who heads up and coordinates the IBD research. Pharmacists, paediatric gastroenterologists, and you'll hear again from Dr. Warren Heyer this afternoon. Psychological medical unit, and you'll hear from Dr. Inspector. And of course our radiologists and histopathologists, whom we interact with really very closely. But it's really all knitted together and bound together by the patient panel, headed by Francis Hamlin here, and by you as our patients. We genuinely do want to hear from you and get feedback about how to improve and what's needed to really better the service. So, what are the services? Just to tell you a little bit about the clinical service, trials, laboratory research and teaching and education. For the clinical service, we have IBD clinics which run daily. There's also complex IBD clinics, and I particularly run a clinic on a Tuesday afternoon looking after particularly complex inflammatory bowel disease. I also run a young person's inflammatory bowel disease clinic with a colleague, Dr. Akbar and Dr. Warren Heyer. We've got something called a virtual clinic, which might sound a little bit remote, but it's a way actually we try and look after patients who take anti-inflammatory, anti-TNF drugs in a very cohesive and careful monitoring way. So we can really carefully check out that everything is being done properly here. We also have infusion clinics, and Marion O'Connor will tell you a little bit more about this afternoon, giving the drugs, the anti-TNFs, but also things like iron infusions, vitamin D, and so on. We try to really improve the information. We've recently devised, and Hannah, one of our IBD nurses, has been very much at the centre of this, trying to make the information better. So producing a new leaflet, which you can all pick up, and I'm sure we're going to have some copies of this out today. We've also got a website. You're not meant to read the details of this, but the website for inflammatory bowel disease is again something we're working on and trying to improve on a very regular basis. Within the hospital, we've got something called the intranet. So it's the within the hospital internet to try and again improve the transfer of information, not just between healthcare professionals, but also to make sure that patient information and so on is constantly improved and updated. So just down the tab on the left-hand side there, you can see that we've got a What's New in IBD section, meetings going on, information sheets, information on new diagnoses in a number of different languages and so on. And this is really to try and make sure that the information that's provided to all the healthcare professionals within the trust is optimised as much as we can. Again, I've got a major interest in trying to devise algorithms of care, and earlier this year I published a book with a colleague who's currently in Hong Kong, Siu Ung, very much using an algorithmic approach to management of inflammatory bowel disease. And as part of a bigger initiative, it's to try and take this sort of approach of algorithmic care to the next level. And I'm working with some colleagues, Marcus Harboard and Siu Ung again, to try and devise very much a web-based algorithm of care project. You can see here an example of the front page, whether it's Crohn's disease or colitis, whether you're an adult or a child. And then by clicking onto some of those particular blocks, it can take you deeper into various algorithms of care. And the deeper you get in, there's information not just for clinicians, but also information for patients. And the real vision of this is to try and make this as global as possible. And this can be tailored to individual hospitals, individual countries, and modified depending on the needs of any particular individual country, and indeed any individual. This is an example of it here. Again, this is just another example. You can see a little tab maybe just at the top showing that there are pages for the doctors, but also pages for the patients, to try and, again, visualise risk and benefit in different ways and try and really make things a lot more visually accessible as far as the information goes. What about the young persons or the transition clinic that we run? Well, again, I think this is a really important part of inflammatory bowel disease care. Crohn's disease and colitis are increasing in incidence, particularly in young people. So when a child is diagnosed with it, we've got to really try and ensure a seamless transition to the adult care. As people actually get more responsibility, and everyone's an individual, is trying to make sure that the baton is handed on so that the parents can actually transfer responsibility with the guidance of the healthcare professionals to that person. What we've been doing is working with a paediatrician, Dr. Hart, who you'll hear from later, as well as the IBD specialist nurses. We run this clinic in the outpatient, in the adult outpatient setting. So the children move from Jack's Place, which has got all the pictures and all the fun things going on, to the much more sort of stark adult setting. But important that I think people make this transition as smoothly as possible. They're currently running monthly. We allow 30 to 40 minutes for a new patient because it really does take time just to start getting to know each other and forming that rapport. And actually a patient would stay within this setting, within the transition clinic, until it's felt by all parties appropriate and it's the correct time to move up to the full adult services. We've got input very much in this particular cohort from the psychological medicine unit and also our dietitians. And these patients form a major part of the weekly MDT meetings. These are the jewels in the crown. I haven't got any crowns to add here, but these are seriously the jewels in the crown. Marion O'Connor here on the top right is receiving a Nurse of the Year award, so a huge credit to her. And you can see that the team there, and the lady on the left in the middle picture is Susan Osborne, who's one of the administrators and secretaries, and we couldn't do without their help and support as well. You've heard about the Wolfson Endoscopy Unit, a unit we're really very proud of here. This is recognised as a World Centre of Excellence, and particularly inflammatory bowel disease patients, we do need the capsule endoscopy service, the double balloon service. It means that you can sort of walk with a balloon down through any part of the gut and get to any part of the gut you need to stretch up strictures and do that sort of very high technical endoscopic work. And also the surveillance service for cancer. Clinical trials, I think, are really important, and we run a very active clinical trials unit here now at St Mark's. We've got 3 trials running for patients with ulcerative colitis, 2 for Crohn's disease, and 2 for pouchitis. There are lots of details, and we'd be very happy to provide information about these. And I think if you are interested in any of these, we tend to put posters up in the outpatient departments, and it's simply a matter of asking your doctor for any information about these. Particularly, I tend to choose trials where I think the drug is a very promising drug, and also where people who've got very difficult or refractory disease and surgery is not something that people want to contemplate, to give people options and other possibilities to try other avenues of what's available and what will be the future of drug management. But in the rest of this talk, I'd just like to focus on a few more advances, what's really going on in the bigger world out there. What's new in the causes of inflammatory bowel disease, what's new in how we really approach the treatment and management, the goals and the aims of treatment. I think these are moving a little bit. Can we really predict and look into a crystal ball very early on and try and judge how disease is going to behave and what's new in the medical therapies? Now, we don't know the cause of inflammatory bowel disease, but this is sort of the way I think a human brain can begin to try and get to grips with it in this sort of simplistic way, that there's something genetic, there's a genetic background, and then there's some environmental factor which makes the immune system go a bit haywire and confused. This is the genetic revolution. I always like this picture because the two chaps at the bottom left there, it's Crick and Watson, who of course discovered the structure of DNA, and there's something a bit genetic about them. I think it's the eyebrows or something like that. But, and I never know which one's which, actually. If anyone knows, do tell me. I must make sure I find out which one is which. I always get completely sort of into the eyebrows there. And at the bottom right is John Sulston, of course, who headed up the Human Genome Project. I think we thought we'd done jolly well in 2003 to really get to grips with the Human Genome Project. I think we're knowing now this is the tip of another iceberg, which I'll tell you about. But the genetics of inflammatory bowel disease is genuinely an absolutely fascinating story. We started with twin studies, and that was the first realisation that there was a genetic flavour to these diseases, in that monozygotic or identical twins were more likely to get the disease than dizygotic twins. But then in 2001, two major groups from different parts of the world found this first gene for Crohn's disease, the NOD2 gene. And that gene encodes a protein which very much tells our body how to interpret bacteria and bacterial signals. So we got sort of slightly closer to what's going on. But since that time, technology has really meant that we've learned a lot more about it. Now there are actually over 160 genes that we know are involved in Crohn's disease and ulcerative colitis. And actually this is more than any other complex disease like hypertension or type 1 diabetes or schizophrenia. So I think the amount of work that's been done in the genetics of inflammatory bowel disease is really second to none. What's really interesting is that Crohn's and colitis, when you look at the genes, are quite heavily linked. In fact, about a third of the genes overlap between the two. So even though we think of Crohn's disease and ulcerative colitis as quite separate, actually when you get down to, if you like, the molecular level and what's going on at the genetic level, there's a big overlap between these diseases. But that's all very well and good, and you're probably thinking, well, how is this going to help me? And I think this is the question that I really want to think about in a bit more detail as well. How can we use all of this wealth of genetic data to really help you as the patients? Well, I think one way we can do it is through something called pharmacogenetics. What that boils down to is, can we try and predict, using the genetic makeup of any individual, who can respond or not to a drug, who can get side effects or not from a drug? So if you like, if we could just have a printout of genetic makeup, would that begin to help us to know to go down treatment X or treatment Y, depending on who's going to respond or not or get side effects? Again, we're part of a much broader UK initiative here as part of a consortium called the Pharmacogenetics Programme. And actually there are over 100 sites now participating in the UK, all inputting data into these initiatives. And we're doing some really exciting work now trying to work out answers to some of these questions that I've posed there this morning. But no matter what the genes are doing, I'm afraid it only makes up for about 50% of the risk and the cause of Crohn's disease, which means that there's another major circle there which is important, and that's the environment. That's the environment that we all live in. And a major part of the environmental trigger in these diseases is our gut microbiota. That, if you like, is the bugs that live within us all the time, that is sitting there all the time. Also, I'll mention just briefly some other environmental factors: smoking, diet and stress. So as I said, we thought we'd done pretty well with the Human Genome Project in 2003, but we're really just touching the tip of the iceberg of the Human Microbiome Project. That's really trying to understand the genetic makeup, not just of us, but also of all of our bugs within us, and they form a large part of us. So I always think of the gut microbiota as a black box. We've got 10 to the power 14 bacteria in us. Now, when you think we've got 10 to the power 13 cells in our body, we are actually a minority part of our gut flora. It's always quite a thought. It's actually the most densely populated ecosystem on Earth, and it provides traits we haven't had to bother to evolve on our own. It's been considered by some to be a virtual organ, possibly akin to the liver in terms of its size and metabolic function, but we just really haven't got to grips with understanding what exactly it's doing. And the genes in our gut flora outnumber our own genome by about 100-fold. We're in the next wave of trying to understand what's going on there. So we need to know who's there and what they do, but I genuinely think it's a gold mine to really try and work out. And I think possibly if we can work out a bit more about this, this might provide some more important targets, potentially druggable targets, to help people with diseases which are very much driven by the microbiota. One mention of smoking and inflammatory bowel disease, and as I'm sure you all know, if you've got Crohn's disease, your doctors and your nurses will bang on to you saying you shouldn't smoke. And the reason is really, really clear. And this is an environmental factor where there is genuinely no debate at all. Smoking and Crohn's are bad news together. They have a worse prognosis, more frequent relapses, increased use of medication, and they don't respond to the drugs as well. And yet by giving up, by quitting smoking, you could actually decrease your chance of a flare by 50%. And that's not to be underestimated when you look at the efficacy of some of the drugs that we use. So simply quitting smoking is such a major, major thing that can be done. What about vitamins? Well, I'll just mention briefly vitamin D, because I think this is really a rather interesting vitamin with regards to inflammatory bowel disease. There's been a sort of change in how we perceive vitamin D, what I've said, the changing faces of vitamin D. I think we always used to think of vitamin D in the context of calcium or bone metabolism and rickets, and you can see some of the very dramatic examples of rickets in a young child on the left there. But also in bygone days, vitamin D was thought to play a major role in treating something like tuberculosis. So in the old TB sanatoria, people would go to these sort of places, their beds would be pushed outside into the sunshine, and they'd be given sunshine treatment and cod liver oil. And of course, all of this is very vitamin D rich. Also, there's some data that vitamin D is important as a chemopreventative agent, so in stopping or preventing cancers, potentially colorectal cancer, potentially breast cancer, and potentially prostate cancer. And actually, there's a bit of data that all-cause mortality is increased if you've got a low vitamin D. So I think there's a message there. I always find it's a fairly potent message that we probably need to be running our vitamin D levels fairly high. In the context of more autoimmune diseases, there's certainly some evidence that it has a role in multiple sclerosis, but also I think in inflammatory bowel disease. Now, we don't know exactly what we should be doing with it yet in inflammatory bowel disease. Suffice it to say it's important. And there's one trial just suggesting that if you get the levels up, you might help to treat. So you're all going to go off and book a summer holiday or a holiday in the sunshine now. You can maybe see if you can get that on prescription. What about diet and inflammatory bowel disease? Well, I'm not going to talk in much detail about diet because you're going to hear from a really excellent dietitian this afternoon. It's really sad that we still don't understand much about the impact of diet on inflammatory bowel disease. And I always feel that it's poor information we give you as patients about diet and inflammatory bowel disease. And I think that's because it's really been very difficult to unpick at the research level what is causing what. There is certainly some fantastic evidence that modular or polymeric diets are really good treatments. That's using this as solo treatment for inflammatory bowel disease, and particularly young people are really good at taking this. There's a bit of other evidence about increased carbohydrates, certain refined foods, polyunsaturated fats, but really the evidence that we're giving I think is quite poor, but I'll leave it to our dietitians to talk in a lot more detail later. A simple comment about stress and inflammatory bowel disease. A lot of you often come to me and say, I'm sure stress plays a role in my disease. And I've got no doubt it does. It's not the cause, but it's, I think, one of those permissive factors that's sprinkled on top that doesn't help. I think the real thing is, can any form of therapy that's targeting stress help to treat the disease? And people are beginning to do some study work on various forms of hypnotherapy and so on. The immune dysregulation, I'm simply going to mention our excellent lab, which we collaborate with here as part of Imperial College, headed by Professor Stella Knight on the right here. And it's a beautiful cell called a dendritic cell you can see in the middle at the bottom there, with these lovely veil-like projections, which really work very hard to try and keep our bodies in order. I suppose the holy grail of what we're trying to achieve with the lab that we're working with is trying to make a much more targeted immunotherapy. So the whole list of drugs that we've shown you so far, steroids or anti-TNF, they affect the whole immune system. But wouldn't it be good to have something which could really target the gut and the gut alone without causing all the other systemic side effects that these other therapies give? What about the approach to management? Well, long-term Crohn's, and people with Crohn's, I don't need to tell you this, it's a relapsing, remitting disease. It comes and it goes, and over time, damage to the bowel accumulates. But what we need to aim is to try and get that line lower down so that in the long term, over decades and decades, the whole impact and damage to the bowel, which equates to life damage, is reduced to the minimum level. So I think really the goals and the aims of management are changing from just getting a clinical response to really having a sustained remission with minimal side effects of therapies, and to get the bowel as healed as possible. And that's, I think, the real goal that we're aiming to achieve now. But again, it's all to do with trying to get the right balance, which is so much of what we try to do in life. Not under-treating difficult disease, not over-treating minimal disease. Because if there's just a very mild disease course, there's no need to have drugs with side effects. That sort of disease can have no or minimum treatment. But if the disease is going to be troublesome and difficult, then I think coming in early with early aggressive treatment is the right thing to do. Can we look into a crystal ball and predict who's going to get bad disease or not? Well, we're not clever enough to do that yet, but there are just some general feelers that we do know. Youth, I'm afraid, is a risk factor, so people who get disease young have got a poorer outcome. Smoking is also a predictor of bad disease. But the three at the bottom are the real ones that we use clinically. How bad the disease looks when we look in endoscopically. Is the rectal or perianal disease? That can again be linked with poor outcome and extensive small bowel disease. This is just clustering together some of the trials where it makes the point that if you get in and treat the disease hard and early, you've got pretty much double the chance of getting people better. So I think for those people who are going to have a troublesome, difficult course, coming in with early and hard treatment is probably much more likely to achieve the goal that we're aiming for. What's new in anti-TNF therapy? Well, again, anti-TNF therapies are things like infliximab and adalimumab, and there's real choice, I think, there at the moment for people. And it depends very much on what you want out of things, whether you want to self-inject or whether you want to come in and have infusions. What's new in 5-ASA therapy? Well, these are drugs like Asacol or Pentasa or Mesavant. Well, I think there's a real appreciation now with chronic diseases that we're all human beings and people forget to take tablets. So it's trying to make taking tablets as easy as possible. And there are a lot of these therapies which are once daily now or twice daily. So rather than trying to remember that dose in the middle of the day, there's a real move to try and have a lot of these therapies as once daily therapies. What's new in azathioprine therapy? Well, I think, again, it's a real move to try and personalise therapy, using some particular drug levels to try and really monitor and do this job better. But it's not just about the drugs. We know that even when the disease is in remission, people are troubled. They're troubled with a lot of these symptoms: fatigue, fecal incontinence, or even the worry of fecal incontinence, pain and food enjoyment, being able to go out and socialise and use food as a social thing. So we think here it's really important to have a holistic approach and to communicate well. A single slide on alternative therapies, because I often get asked a lot about this. We know that a lot of people use probiotics and various other things there, and I'm always very happy to talk about some of these alternative therapies and give data on these to people. Engaging and empowering you. We're working a lot with this particular bit of software at the moment to really try and help with decision making. A lot of this is about preference-based decisions. This is simply to show that this particular tool is called a decision aid tool. And at the bottom there's the evidence base, so what is the evidence that a certain drug works or not. In the middle is something called the weightings, and this is where you come in. What's really important to you as the patient? And you can move the bars along on this particular tool depending on what's important to you. How important is it to get into remission? How important are some of the side effects for you personally? And then it comes out with an option score at the end of the day. But what it's really aiming for is trying to get the right decision in any circumstance for you at a given moment. And that's it for me today. Thank you very much indeed.